Great. So welcome everyone as folks continue to trickle in. It's my pleasure to welcome you all to the Mary Seeman lecture that's offered today as part of the University of Toronto Future of Psychotherapy Conference. I'm going to be your moderator today, and before I introduce our esteemed speaker, I just want to remind everyone to please use the Q&A function to ask your questions and share your comments, because I'll be checking there, and it gets a little bit busy if folks are using the chat concurrently. So please use the Q&A. So without further ado, it's my pleasure to welcome and introduce Dr. Pamela Collins. She's a Bloomberg Centennial Professor, Chair of the Department of Mental Health, and Director of the Johns Hopkins Center for Global Mental Health. She seeks to increase mental health equity for adolescents and adults around the world through reciprocal innovation and research at the intersections of global mental health, HIV, and urban adolescent mental health. Her current projects in sub-Saharan Africa integrate psychosocial interventions into routine HIV care in Kenya and using digital tools into prayer camps in Ghana. Thank you so much for sharing your time and expertise with us, Dr. Collins. I'll hand it over to you.
Great. Thank you so much. I'm really delighted to be here, and I want to thank Drs. Vigo, Rajivan, and Singala for the invitation to join you today. So today I'm going to discuss the implementation of an adaptation of trauma-focused CBT in a low-resource setting, and I'll do that by sharing some insights from my work at the intersection of HIV and global mental health. I have no disclosures, a reminder of the learning objectives. So HIV and mental ill health are two enormous global public health challenges. As with many medical conditions, mental health plays an integral role in the risk and outcomes for HIV, and HIV infection influences mental health status over the lifespan. Across the decades, the multidisciplinary nature of HIV care has provided an entry point for psychological interventions in very diverse settings. And what we learn about their integration into HIV care can inform how we integrate these interventions into primary care and other services in settings where specialist providers are scarce. So these are data from the 2023 Global Burden of Disease study that remind us of the prominence of HIV and depression as leading causes of poor health around the world for more than 30 years. And you can see the data from 1990, and depression and HIV haven't moved up in rank over the past more than 30 years. So in the latest GBT analysis, depressive disorders as an example of a most prevalent common mental health condition, and HIV are the second and third leading causes of lost health among 15 to 49-year-olds. And I won't spend a lot of time, and I probably don't have to remind you of this, but more than 1 billion people live with the mental disorders, and the WHO's most recent analysis of global mental health data reminds us that mental health systems around the globe are failing to meet their population's needs. And the low treatment coverage for depression around the world specifically is one example, with treatment coverage of depression at 33% in high-income countries and around 8% in lower and lower middle-income countries. And even fewer people receive minimally adequate care, with less than 1 in 4 in high-income countries and only about 3% in low or lower middle-income countries. So a huge need for us to address mental health needs and figure out what are the best strategies to do so. At the same time, the HIV epidemic, right now, around 40.8 million people, almost 41 million people live with HIV. A majority of those people are living in sub-Saharan Africa. In 2024 alone, there were 1.3 million new infections. And I want to point out the two ways of looking at this. That's way too many new infections of HIV, and it's a 40% decline since 2010, with an even greater decline in sub-Saharan Africa, where the majority of people live. So we're moving in a positive direction with the epidemic, yet we have a very long way to go. There were 630,000 AIDS-related deaths in 2024, and 75,000 of these were among children. Again, significant decrease, but again, too many. There's a bidirectional relationship between HIV and mental health. This is the interconnectedness I was referring to, where HIV increases risk for some mental health conditions, and mental health conditions can increase risk for HIV acquisition. And they have shared social determinants that increase risk, from social exclusion, social marginalization, exposure to violence, discrimination, poverty are all drivers in direct and indirect ways. And we know that behaviors that increase HIV risk and behaviors that are stigmatized also have a role in stress and experience of poor mental health. So people living with HIV have greater risk of mental health conditions. Often this is due to many factors, including the direct effects of the virus on the brain, living with a chronic life-threatening illness, exposure to social adversities that intersect with HIV risk, and the consequences of, and I'll talk about depression for the start of this, the consequences of depression co-occurring with HIV are barriers to HIV testing, poor adherence to HIV care, attrition from care, higher mortality, and increased unsafe sexual behavior. So depression is one of the more prevalent conditions among people living with HIV. A number of studies have shown a relationship between HIV and mortality. In our team's analysis of depression and mortality among participants in the African cohort study, this is a longitudinal study that enrolls people living with HIV and a small number of people without HIV in Nigeria, Tanzania, Kenya, and Uganda. Supported findings from previous studies in the United States. Brian Pence has done some of this work. In Tanzania, Sylvia Kaya and colleagues have done some of this work. But their cohorts also showed that comorbid depression and HIV increases risk of mortality. In this analysis, with more than 2,500 men and women living with HIV in Kenya, Tanzania, Uganda, and Nigeria, we see that chronic exposure to depression was associated with a 69% increased risk of all-cause mortality. So essentially, every 25% increase in the percentage of days lived with depression was linked to the 69% increase in mortality. So really making the point that we have to address depression, we have to address mental health conditions in the context of HIV care. And the good news is that integrating HIV and mental health care have been a goal for several decades now. There's an abundance of data, as well as the personal experiences of people living with HIV have made clear the importance of this kind of integration. Many of the countries in which this work of integration has been growing over the last 20 years, however, also have extremely limited mental health services. These are examples of reviews related to integrating mental health in lower income settings around the world. But frontline HIV providers have been lamenting for a long time that they have had insufficient training to help manage people with receiving the news of a positive HIV test and other aspects of the emotional consequences of HIV. And one of the questions that was generated earlier in the epidemic was, we're training people to be counselors, pre and post-test counselors at that time, 20 years ago. So couldn't HIV counselors also be deployed to support mental health? And might other HIV providers be engaged as well? So building on this accumulated data and the voices of frontline workers and the voices of people living with HIV, one of the interesting projects I had the pleasure of being a part of was working with UNAIDS to develop a background paper for the program coordinating board's first ever meeting on integrating mental health and HIV. And this was in 2018. And this, again, really stemmed from a variety of stakeholders, people living with HIV, clinicians in the field, recognizing that this is a priority to be addressed. And by 2019, the US President's Emergency Plan for AIDS Relief incorporated depression care into its country operating plan guidance, meaning that countries that were receiving PEPFAR funding and implementing HIV care were now able, theoretically, to integrate care for depression into their services. And that this was recognized as a need, I think, was an important piece of that. So the advocacy community, of course, has also recognized that social determinants drive HIV infection, and as we know, they also drive mental disorders. And this advocacy and this recognition shaped the development of UNAIDS HIV targets for 2025, which recognize the critical importance of these social determinants, as well as the need for linked services. So for the first time, there were targets really saying that we need to get to the point where less than 10% of people living with HIV, as well as key populations, experience some of the main drivers, experience violence, experience gender discrimination, experience stigma and discrimination. And these same targets called for 90% of people living with HIV to be linked to integrated services, including mental health. And the question then was, well, how do we do that? Well, in 2022, we presented the how for national AIDS programs, how integration can actually happen in a manual that also explains the role of low-intensity psychological interventions in helping address mental health needs. So in the manual, we outline a set of evidence-based interventions that have been used in HIV care and are relevant both to psychological needs, but also to substance use conditions as well. And as you heard from Dr. Nadkarni in the previous talk, the idea behind low-intensity psychological interventions is that these are adaptations of evidence-based interventions into scalable interventions that are modified to simplify their implementation while maintaining the active components of the intervention. And psychological interventions are effective for many of the most commonly occurring mental health conditions among people with HIV. A recent narrative review of mental health interventions for people living with HIV in low and middle income countries specifically synthesized findings from 30 studies and found 18 of those focused on psychological interventions. And these are the interventions that were identified in this review: cognitive behavioral therapy-based interventions, problem-solving therapy, psychosocial support groups, mindfulness-based interventions, and rational emotive behavioral therapy for alcohol use and other brief alcohol interventions. And the studies sought to understand both which ones were effective, but also how do we understand the components of effectiveness. So they found amongst these studies that significant intervention effects were associated with a lower caseload per provider for psychological interventions. Interestingly, provider qualifications, that is, whether the provider was a specialist or a lay provider, the delivery approach, whether this was a group-based intervention or an individual intervention, the number of sessions, adherence, these were actually not significantly associated with treatment effects. In fact, adherence looked like it would be significant, but that actually did not attain statistical significance. I'm going to go back for one. But one of the important findings among the studies with significant effects was the number of active ingredients, active intervention ingredients that were present in the intervention. And studies with significant effects were more likely to be testing interventions with 3 or more active ingredients. And when you look at this list of active ingredients, relaxation, meditation, psychoeducation, venting, social support, coping skills, problem solving, cognitive restructuring, behavioral activation, physical activity, or livelihood skills. These are obviously going to be quite familiar to this audience. But the active ingredients associated, the three that were actually associated with significant findings were venting, coping skills, and cognitive restructuring. So much of my work in this space began in the last 8 years, working with colleagues in Kenya. I would say I've worked in the HIV and mental health space for many years, starting with prevention, working with women with severe mental illness and prevention, looking more broadly at how do we integrate those kinds of prevention interventions, behavioral interventions for prevention into care. And then moving on to how do we train multidisciplinary teams to support the mental health of people living with HIV. And now this work has moved more specifically to working with adolescents living with HIV. But I'm going to give you a bit of history of that work before we engage young people living with HIV, and then we'll move into the work that we're currently doing with HIV. So Kenya is an East African country with a population of more than 55 million people. There are about 115 psychiatrists, 460 mental health nurses. There's not data available at present for child and adolescent providers. And I don't have data on this slide around the number of psychologists. However, in that population of 55 million people, around 1.3 million people live with HIV, and around 2,800 adolescents were newly infected with HIV in 2024 when this data was reported. Just going to make sure there's not a message for me here. Okay. There was recently a multinational cross-sectional study of youth mental health conducted in Kenya, Vietnam, and Indonesia. And this was a rigorously done prevalence study among 10 to 17-year-olds. And we learned from that study that around 12% of Kenyan youth have any mental disorder, around 4%, almost 5%, reveal suicidal behavior, and around 1.2% reported self-harm in the previous year. Looking more broadly at Kenyan youth and more convenient samples, we know that World Bank data tells us that about 36% of the population lives below the poverty line, but youth experience many exposures to traumatic events, from sexual abuse, gun violence, injury, violent death of loved ones, or simply the loss of loved ones. And in the context of the HIV epidemic, bereavement due to parents' loss due to HIV over the past decades was certainly one exposure to trauma for young people. Urban youth in general have had the highest exposure to trauma in Kenya. So I'll talk briefly about the prevalence of mental health conditions in African adolescents. So taking a step back, there's a high prevalence of these conditions among adolescents living with HIV among African reviews of this work, with around 25% having any psychiatric disorder and around 30 to 50% having any behavioral difficulty. Some of the drivers are stigma, bullying, peer violence, poverty, school disruption, family problems, and older age. More studies show a higher prevalence of mental disorders among adolescents and young people living with HIV. Some of the sequelae of psychological distress among adolescents and youth living with HIV include disengagement from HIV services, similar to the adult data, non-adherence to antiretroviral therapy, viral non-suppression, and high-risk sexual behavior. So how do we address the mental health needs of this population? A brief review: task sharing is one of the potential solutions. In settings where we have a relative scarcity of mental health care providers, task sharing can help. So our team of Kenyan and US mental health specialists brought our years of experience testing models of task sharing and task shifting to extend human resources for mental health in this context. And here, just as a reminder, task shifting involves using abbreviated training of less specialized health workers to support care. And this delegation of tasks can occur across many levels of specialization. And this diagram shows one level of task shifting, which is delegating tasks of physicians to non-physician clinicians. Another level is shifting those tasks to nurses, onto nursing assistants and community health workers, and then onto peers. So you can see how task shifting can involve people with even more abbreviated or less experience of formal training. For the past decade, the World Health Organization has been developing resources for evidence-based guidelines on mental health care, specifically for how do we do task shifting well. And now a question over the years has become, when we're task shifting, how do you ensure that these interventions are delivered with quality? So I'm going to talk a bit about the initiative Ensuring Quality in Psychological Support, or EQUIP, which is a tool to support competency-based training for psychological or psychosocial support interventions. I introduce this now because this was my entry point into working with adolescents in Kenya and figuring out our best strategies for delivering mental health interventions. The EQUIP initiative began a few years ago with the eventual goal to create an online resource, which currently exists. And if you haven't seen this website, it's worth visiting, that provides resources for assessing competencies of mental health workers who are being trained to deliver evidence-based therapies. The EQUIP really hinges on this tool called Enhancing Assessment of Common Therapeutic Factors, or ENACT. ENACT is a tool that's based on a clinical evaluation method of observed structured clinical evaluation. And it is a combination of common therapeutic factors, which you'll see in the next slide. It was originally developed for use in Nepal and has now been adapted for use in many different settings, with the goal of ensuring that skills that are shared across psychotherapies could be assessed by any kind of provider. So here's the 15-item ENACT tool. And what's important for you to see here is that this tool essentially looks at 15 foundational competencies, but I want you to notice that there are levels, level 1, 2, 3, and 4, that are rated when one is rating a therapist or lay helper's performance. Level 1 means that the behavior that you're observing can be harmful, is harmful. Level 2 and level 3 show, improved levels of competency, with level 3 being quite reasonable, and level 4 really standing out as someone who is highly competent in delivering these skills. So my team joined the EQUIP consortium, which was a group of 7 sites selected to test these platform tools. Ours was a collaboration among the University of Nairobi, Nairobi County Mental Health, and the University of Washington, where I was based at the time, and Cities Rise, which is an NGO focused on youth mental health. And we entered this project based on our experience with trauma-focused CBT. And our goal was to prepare providers to treat adolescents with anxiety, depressive, and trauma symptoms using trauma-focused CBT, but introducing these tools for competency assessment. Our experience of trauma-focused CBT was based on work that my colleague Shannon Dorsey and her colleagues had done in both Kenya and Tanzania for many years. Shannon has been working in Western Kenya for many years, working with school-age children, and this is their large trial of the 2 countries that was published just a few years ago, which was a randomized clinical trial of 640 children who received 12 weeks of trauma-focused CBT. And this trial showed that trauma-focused CBT, in this case, also delivered by less specialized providers, was more effective than the usual treatment that children would receive. And at the 12-month follow-up, the differences were maintained in the Kenyan sample, both rural and urban, where children experienced actually greater stress and adversity. The training model that was used for TF-CBT and that we adapted for our work is called the apprenticeship model. And in this model, was designed specifically for task shifting, right? This is a model specifically for people who are not specialists in mental health, who are learning these tools. And so this TF-CBT apprenticeship model involves 2 weeks of training. And about halfway through those 2 weeks of training, after the first week, when the trainers and supervisors have had a chance to see how the trainees are interacting, how they're interacting with the material, what their performance is like, a set of peer supervisors are selected from the training group, people that stand out. When the training is completed at 2 weeks, there follows 3 to 5 weeks of supervised practice groups. So the group that's just trained is going to do practice role plays with each other with regular communication with a supervisor. And in this case, that supervisory communication is by phone because the trainees and supervisors may not necessarily live in the same place. But after that 3 to 5 weeks of practice groups, the community health volunteers or whoever's being trained begin to see their first client with high levels of supervision. After a period of 6 weeks, they can add on additional clients at a faster rate. The treatment itself takes around 6 to 12 weeks in this model, and the community health volunteers then meet weekly with their peer supervisor during this time. So in our EQUIP study, we were comparing this model of the apprenticeship training, but adding with the addition of the ENACT common factor assessment of competencies. Okay, and so this is just showing you how our study of the ENACT competencies. We did a baseline pre-training assessment of competencies with the trainees. We then did an immediate post-training assessment of competencies. And then we let them move through the practice period and move through some of the supervisory work. And then at which point we did a post-assessment. That post-assessment was not necessarily at the end of the supervisory period. Sometimes it happened in the middle, but it allowed at least a few weeks of supervisory experience before these competencies were tested again. This is just a list of the partnerships of the groups that were involved in this. And I raised this because our partnership with the Nairobi County mental health unit was so important in this work because, number one, we were training providers who worked with the county, and we were also we also had our ear to the concerns of the county that was responsible for delivering care. So our activity involved first pilot training of trauma-focused CBT to 5 community health work promoters and 5 psychologists who were part of this mental health unit for Nairobi County. We started this in the fall of 2019. We're on our way to Kenya to return for a larger training after having done this small pilot feasibility training, and the world temporarily closed as a result of the COVID pandemic. So we quickly adapted our strategy for this work in consultation with our colleague who was the director of mental health at the Nairobi County Mental Health Unit. And she identified 2 needs. She said, we have a lot of young people who are distressed, and we don't have enough people to meet their need. And we want to do something, we want an intervention that we're able to engage young people with, and something that's rapid during this time of acute need, which was during the COVID lockdowns. And our solution was to create a brief transdiagnostic intervention that derived from trauma-focused CBT, and to train a set of community health promoters using the same apprenticeship model. But this time, doing that training on online. We had trainers who were in Western Kenya, and our trainees were in Nairobi. So part of this was done through Jitsi, a low bandwidth digital platform. Therapy would be conducted via telephone with adolescents living in an informal settlement, and supervision occurred via telephone. All of this, of course, because of the COVID restrictions. So the intervention that we derived was called PROACT, which stands for psychoeducation, relaxation, problem solving, activation for behavioral activation, and the C and the T come from cognitive coping. So this is a brief intervention, 5 to 6 sessions, that is delivered by providers or peer supporters. In this case, we pilot tested this intervention with our group of community health promoters in Nairobi. And I'm just going to show you some high-level outcomes of what we learned about the competencies of these providers using this model of training, practice, intensive supervision. So the first thing that we learned was that when we assessed people immediately post-training, so the competency is baseline competency and then a competency assessment post-training, we really saw very little difference in competencies. When we assess people post-supervision, and these are the outcomes you're seeing here, we saw a significant reduction in potentially harmful ratings after supervision. And we saw an increase in level 3, which are basic competency, and level 4 or advanced competencies post-supervision. So again, reminding us that, first of all, we were relieved that it was feasible to train these providers in the midst of the COVID pandemic using these kind of adapted ways of doing the training digitally. But importantly, the gains happen after people are practicing using skills and receiving supervision. So taking this data, we have pilot outcomes for the intervention itself, which showed promising positive gains in reduction of anxiety using the RCAD, reduction of depressive symptoms using the RCAD as well among a small group of youth that were that received the intervention here. But the main goal of this study really was to understand the competencies. But given the promising nature of the intervention findings, we applied for funding to do a larger study of effectiveness of PROACT and receive funding from the National Institute of Mental Health. This is a study that's ongoing, and it's a hybrid effectiveness implementation trial. In terms of trials of this sort in sub-Saharan Africa, the largest African trial to date of adolescents living with HIV and receiving a psychological intervention is a Zimbabwean study by Sims and colleagues, testing an intervention called Zvandiri, which was a peer counseling intervention really developed to support adherence to care and is extraordinarily successful in supporting adherence to care. When they first tested Zvandiri, they discovered that yes, that it supports adherence to care, but it does not actually reduce depressive symptoms. So in this study, they paired the peer counseling intervention with a peer counselor trained in problem-solving therapy. So you could get the typical Zvandiri counseling or this counseling focused on problem-solving therapy. And what this study looked at viral non-suppression, which actually decreased in both arms. But the secondary outcome was mental health status. And they found that the problem-solving therapy arm led to significant reduction of depressive symptoms, both from the PHQ-9 and the Shona symptom questionnaire. And for those of you who are not as familiar with HIV care, one of the goals of introducing mental health interventions into HIV care has been to both meet the mental health needs of clients, but also to understand whether or not treating the mental health problems, treating depression, anxiety, or trauma might also improve HIV outcomes, such as viral suppression or adherence to care. So in this study, the depressive symptoms were reduced with the intervention arm, with an evidence-based psychological intervention specifically, but the viral suppression actually decreased in both arms. So in our setting in Kenya, we now have we have this project focused on integrating mental health for adolescents living with HIV. This very happily coincided with a presidential task force on mental health in Kenya that had identified deficiencies in mental health care competencies and a desire to make mental health care more available in primary healthcare settings, as well as a desire to actually integrate mental health services into existing healthcare programs, including HIV services, and doing this by essentially training these providers and providing them with greater psychosocial skills. So I will tell you a little bit about some of the challenges of potentially delivering a psychological intervention in HIV care. First of all, most HIV services are offered by non-mental health providers, medical officers in the Kenyan context, clinical officers, nursing officers, and a variety of counselors who often are focused on supporting adherence. Peer educators also play a major role in care, especially in the treatment support for adolescents and youth living with HIV. So one of our questions to our stakeholders, our colleagues that we engaged as we were planning the study was, who would deliver PROACT? Many people felt peer educators were the perfect provider for such an intervention. But I'll tell you what we decided with the group of people that we engaged. Another challenge is that school-going youth who attend boarding schools actually make up about 20% of adolescents and youth living with HIV. So they only access mental health care when they're on breaks, so on term and midterm breaks. So the question was, is it feasible to start someone on a psychological intervention who may go off to school and may have long gaps between sessions? What might that look like? So those were a few of the concerns that we had. Also, I'll come back to some of the structure of HIV care and how we can think about the implications for integrating psychological care. But first, I'll tell you about the structure of our trial. So we proposed and are in the midst of conducting this cluster randomized trial of adolescents living with HIV who are ages 16 to 24 years old. We are working in 30 clinics, so 15 intervention clinics and 15 control clinics across 3 counties in Kenya. We did baseline screening for depression, anxiety, and trauma, with depression, the PHQ-9 score, really being the deciding factor for inclusion. If young people had severe symptoms, they were referred to a specialist, but they did have the opportunity to re-engage so that they could receive the intervention if they were in an intervention site. Young people with mild to moderate symptoms were either received standard of care in control sites, or the 300 that we were aiming to recruit in intervention sites received PROACT. Our primary outcome is the PHQ-9 at 3, 6, 9, and 12 months, but really 6 and 12 months being our primary time points. And the secondary mental health outcomes are anxiety and trauma scores. Our secondary HIV outcomes are antiretroviral adherence and viral load. So I'm going to briefly show you what our effectiveness outcomes look like in their assessment. So depression is using the PHQ-9 and the ASQ suicide risk assessment, and you can see our scoring criteria. For anxiety, we use the GAD-7, and for trauma symptoms, depending on age, either the 20-item CATS or the PCL-5. And then treatment adherence was self-report as well as routine data abstraction from the chart. As we thought about PROACT and what the actual intervention would look like, we determined that we would stick with a in-person one-on-one intervention or by phone delivery. We thought about whether or not this should happen in groups, but with the logistics of the HIV clinics and the kinds of providers that we ended up training, one-on-one individual treatment seemed to actually was more feasible. So who delivers PROACT? We trained a variety of providers in HIV clinics, and we left the decision up to the individual facility to tell us, in your facility, who would be the most appropriate person to deliver this intervention. So this meant that our trainees were sometimes nurses, sometimes peers, sometimes adherence counselors, rarely, but sometimes clinical officers. But we had a variety of people who had multiple roles in HIV care. The number of sessions, expected sessions for PROACT delivery was 4 to 6. The duration of the sessions, we expected 30 to 45 minutes. 45 minutes has been more the norm. And the expected time between sessions would be weekly, but we recognized that we would have to have flexibility dependent on the schedule of clinic visits for adolescents and youth living with HIV. And in some clinics have specific youth-friendly clinic days, which do not necessarily occur weekly, but those are the days on which young people would come for their appointments. And as I mentioned, the issue of school and delays in returning to the clinic as a result of boarding school was also a concern, or at least a flexibility that we knew we needed to allow. And again, these are our outcomes. And I'll give you a bit of an update on where we are right now with this study. Of the nearly 8,000 young people receiving services in these clinics, we approached almost 2,500, screened around 1,700, and found that more than 1/3 were eligible for treatment. We've reached all of our enrollment targets, so we have 600 young people enrolled. Some of them have undergone 3-month follow-up, some 6-month, and actually we have people who've undergone 9-month and are beginning the 12-month follow-up for a subset of young people. This follow-up data was being collected last year in 2025, and along with the disruption in PEPFAR funding that happened, many of our clinics lost staff. Depending on the sites, some staff were permanently terminated. Others were temporarily paused in their work and then resumed the work. And our study was paused temporarily, but the work resumed, paused at the end of May, the work resumed in September. So that's been another interesting experience of the providers managing the stressors of the system and kind of political issues, but they resumed, and the treatment has resumed for these young people as well. So what are we finding in this group of young people? We're finding a high burden of common mental health conditions, with those among the 1,719 youth screened. You can see here that around 1/4 of them had mild depressive symptoms, moderate in about 9%, severe in close to 5%, with, of course, the majority not experiencing depression, but a pretty significant group of young people with suicidal thoughts here at almost 12%. Then among the 600 that we enrolled who all had depressive symptoms, you can see here that these young people have a significant level of anxiety, both mild anxiety, moderate anxiety, as well as some severe anxiety. Trauma experiences, trauma symptoms are around 20% for both for the group under 18, but higher amongst the over 18 group at 29%. And this is just a glimpse of the social demographics of the group, where median age is around 19, a predominance of female participants. The majority of this group is in school, around 60%, And you can see the distribution around 23% in primary school, still 66% in secondary school, and 11%, close to 11% in university, tertiary school. Again, almost a quarter are out of school, but employed. In this group, you can also see that a large number of people have lost a parent, either father or mother, which is the definition of being orphaned in Kenya, so 54%, and a majority of these young people are attending a support group. In looking at our data, we've seen that 86% attended at least one intervention session. With the data so far, around 64% have completed the intervention. And when we look at how many completed more than 4 PROACT sessions, we're seeing that about 75% of young people completed more than 4 sessions. We wanted to look at this question of how has school influenced attendance of these sessions. And what we have seen here, if you look at this is schooling status. Are they in school? So the top 2 rows are telling you we have about 176 who are in school, 123 who are not in school. For those not in school, it's taken them about 8 weeks to actually complete the intervention. And for those who are in school, those who are in college, the bottom row, have moved through this intervention most rapidly. And that's likely because there are a number of universities in Nairobi. They're not going off to boarding school, or they're having fewer interruptions, whereas the primary and secondary students tend to complete in closer to 11 weeks time. So what are we learning that can help inform what we need to know for greater global health application of psychological interventions? Well, we're learning, and we still have questions. One question that has been raised by researchers is, how do these treatments actually work cross-culturally? And this is there's more recent work that's coming out to try and tease apart how do we understand the different components of treatment and what they mean in different cultural contexts. But this is an example from a South African study that was trying to understand how cognitive behavioral constructs work among people living with HIV in South Africa. In fact, which are the constructs that are most important for understanding and treating depression in this particular context? And what they found was that behavioral activation of the different components of CBT-based therapies, behavioral activation was associated with reduction of depressive symptoms, improved quality of life, reduced functional impairment, suggesting that in this population, behavioral activation may be of particular treatment value. And so when we think about which interventions to utilize and perhaps which components to emphasize, particularly when we need these interventions to be brief, this kind of analysis can be helpful. So I'm going to wrap up with a few considerations for integrating psychological interventions into HIV care. So first of all, we have to do contextual adaptation of these interventions. PROACT is an interesting adaptation that really grew out of necessity in the urgency of the COVID pandemic. We needed something brief. We needed to bring together core ingredients, core components that have an evidence base, and we needed something that could be trained, that one could train a lay health worker, in our case, community health volunteers, in relatively quickly. And in the context that we're working in, certainly in many parts of sub-Saharan Africa, there is a dearth of specialist mental health care providers. But I think another lesson from this work around task shifting is that every community has providers. It's a matter of figuring out how we engage the human resources that are available, and task sharing is one of those approaches. Task shared providers need ongoing coaching and supervision. This is clear. This is when competencies that are acquired during training begin to be solidified, is after you've had some experience with rehearsal, with supervision. What, of course, we're also learning, and which is, I think, true for all of these interventions, wherever you're doing them, is that providers need emotional support. So the role of supervisor as in most clinical supervisory situations, is to help provide that emotional support, but group supervision helps with that too, bringing folks together in groups. Our current study lacks that. We felt that provided a more challenging situation for our providers, that they did not meet together regularly for supervision. But what we've done instead was to bring them together periodically as a group across sites to learn from each other, to have a chance of experiencing more of this kind of emotional support, hearing what other people are doing to support themselves as well. What is the work of the one-on-one supervision in this situation? We need referral pathways for stepped care. We have to know how to refer people when they have more severe illness symptoms. We were surprised during COVID that so many young people had more severe symptoms than we had anticipated, and ended up referring a lot of people to be seen by both psychologists and psychiatrists. We need medications to be available for people who have more severe symptoms and need that additional kind of treatment. And the health information systems in these clinical settings need to be adapted so that when an HIV provider is seeing somebody for their mental health problems, they need to be able to document that in the chart. That should not be in a separate chart somewhere. The health information systems need to have the space for people to actually include data on depression care and other care.
And finally, sorry to interrupt, just a reminder of the time that it's about 12:50.
Thank you. And finally, the frequency of visits and attrition from care is something that has to be taken into account when we're trying to align visits for mental health needs with visits for medical needs. Frequency may not align very well with what we typically expect for a psychological intervention. So all of these are considerations that we have to take into account. In our current situation in Kenya and many other countries where donor funding for HIV care has dropped significantly, we're seeing rapid system transformation. And by that, I mean health systems are saying, oh my goodness, we need to integrate HIV into primary care quickly because we don't have as many providers, we don't have as many resources. And we're watching how this happens. We're doing this work as this is happening. And I think one of the challenges is that this kind of rapid transformation can lead to deprioritization of mental health care. But this is an advocacy job for all of us that are working in this space. And what's especially important in this context of change are strong links with other community resources that support mental health, as well as strong links to the existing mental health system, no matter how fragmented that might be. I'll end on a happy note. In 2025, for the first time, the World Health Organization's HIV service guidelines include a strong recommendation for the integration of care for depression, anxiety, and alcohol use disorders in HIV care as a result of the considerable evidence base that's supporting integration, and I think for the continued advocacy of people living with HIV and providers in this space. This is our team, our wonderful team, and many of our stakeholders who help to inform our work. And I want to acknowledge my fellow principal investigators and co-investigators, our funder, which is NIMH, and our institutional support. So thank you very much.
Thank you so much for your presentation, Dr. Collins. So I'll encourage folks to continue to share your questions and comments in the Q&A, and we'll get through as many as we can. The first question you spoke to a little bit with your example of the South African analysis and pulling behavioral activation out from CBT. But the question is that when you're adapting psychological interventions to diverse cultural backgrounds, how are you making those key decisions and identifying and selecting core components of the intervention?
Yeah, I think most interventions, it's a great question. When you look at the typical CBT interventions that are adapted in many of these settings, they're using all of the components. So they're not necessarily pulling them out or skipping them. There's another intervention that has been developed in these settings, in low resource settings specifically, which is the Common Elements Treatment Approach. People may have heard of that approach as well, CETA. which is a modular intervention, right? It's a transdiagnostic modular intervention developed specifically so that providers can meet the needs of people who have different kinds of symptoms, right? People don't necessarily only come to you with depressive symptoms. They don't only come with trauma symptoms. They typically come with anxiety and, you know, a mix of symptoms. And I think a model like CETA says, well, let's provide all of the active ingredients, but with supervision. Part of that training is helping the provider to recognize when do I need which module to address which types of symptoms that appear. So it's not necessarily saying, oh, we're making a decision to leave out some components, but more using a transdiagnostic approach. And that's kind of what how PROACT is structured too, as a transdiagnostic approach that says, well, when I'm working with the supervisor, we're going to decide based on the symptoms that this young person brings, what's the best, where do we start? We start with psychoeducation. Do we go to relaxation perhaps? Do we do cognitive restructuring next, or do we do problem solving, right? Those are decisions that are made based on the symptom profile.
Thank you. And the second question is related to the role of families during these interventions, and with special consideration to the context that these studies were done in collectivist cultures. And also I'm mindful that you named that about 50% of the adolescents and youth were orphaned, having lost one or both parents, and that some were spending a large chunk of time at boarding school, I imagine, away from their families of origin and extended families. So perhaps you could comment on how you envisioned and what you saw practically playing out in terms of the role of families here.
Yeah, so the full TF-CBT integrates a family. So a parent or a caregiver is a part of that. So they come to their designated sessions where the caregiver comes. The caregiver is educated about all of this. So family is integral into this. In PROACT, which again is a briefer intervention, you know, I think one of the important things to remember about PROACT is that this is a small intervention in the context of a much larger HIV care setting, where this young person may also be going, as you saw, to a support group, and through the support group may be engaging with other family members. Other family members may be engaging with other parts of their care. So in this example, this is not an isolated treatment. It really is a part of a complex multidisciplinary treatment team's work to support the young person. So there's certainly room for families to be involved in that larger treatment setting.
And I'm curious because you spoke about like the disruption due to the pandemic and the world closing for a longer than we wanted moment in time, that there was this need and unique opportunity that grew that led to PROACT. And I wonder if you could speak to any surprise, like silver linings that came out of having to make that unexpected pivot in terms of where the work has taken you, or what you kind of saw in terms of trying to roll with the punches with this project.
Yeah, I think with that first change from TF-CBT to PROACT, again, happening in COVID, I think what we learned about, part of that was the satisfaction of being able to work with the health system, right? Working with the county system and being able to be responsive, you know, being able to meet a need. And our county colleagues appreciated that, right? So I think the silver lining is also knowing that we can shorten some of these treatments, right? We do know what active ingredients are. Now, we're in the middle of a large effectiveness study, so I'm not going to, until we have our definitive findings from our RCT, but we have used PROACT in other studies as well in the Kenyan setting. And so we will see what those, and those are, we're seeing pretty positive outcomes from some of those larger studies as well. So I think a silver lining is, number one, being responsive to your partners, being able to meet the need of the moment, and being able to equip people to do that. I think the other silver lining in the second disruption, which was in the last year, is something that we mentioned in the panel a little bit earlier, is that many of the providers said that they were able to get through this difficult time because they had these skills. They learned these skills, right? They were practicing some of the same skills that they learned and were delivering to young people in these treatment sessions.
Thank you. Um, and it's nice to see those intended and unintended positive impacts. So empowering what you spoke about in the panel. There's a follow-up question to the family involvement piece. And a colleague in the audience is wondering, are families involved in the consent process as well as during the sessions? And if so, which sections did you find most helpful involving them? And I guess maybe inviting you to reflect on TF-CBT, where it's integral versus PROACT, where it's part of a larger system of the HIV health care delivery.
Yeah, families are involved in the consent when it's a minor, when the person is a minor. So for in this case, for any of the young people who are under 18, we have to have family consent as well. It's a family consent and youth assent for participation in the study. They are not other than that, we did not explicitly invite, this is not a family recruitment session. It was really recruitment through clinics. So when young people showed up for their clinical appointments, that's how the recruitment occurs in the larger study of PROACT.
Great. Thank you for clarifying that process piece. You mentioned in the panel in terms of your wish list, like a wish to kind of crack the nuts that are the barriers to sustainability, and having these projects move from like research projects to really sustainable projects that folks can continue to access in terms of necessary healthcare. And I'm just wondering what barriers you've seen in your work in Kenya and what kind of advocacy you're doing around that in the pursuit of sustainability.
Yeah, there's so many lessons that people have learned from doing this integration work more generally, and one of them is that there are structural barriers in clinics. I think actually, Avi mentioned a recent review of the interventions in HIV clinics that was published just in the last year, but highlighted the similar challenges. We know that rigorous supervision is essential for quality care, and yet rigorous supervision takes time, and there's a cost to that. The things that actually enable quality for an ongoing intervention can be difficult in a busy clinical setting. So I think we need to learn what will be some savings. And this may be where some of our tools and technology can help. This may be where moving towards shorter interventions can help. But there are structural issues both in the way that we train and support people, but also the way that clinics that are not mental health clinics, right, are structured for care delivery. So I'm hoping that so I think our advocacy has to be that, number one, we cannot escape the fact that the co-occurring mental health conditions and HIV are harmful for people, right? It's just harmful for people. And if the goal is really to end the epidemic, if the goal is to see better patient outcomes, we have to treat people. And so we have to keep pressing the case that the way to do this, one of the ways to do this is to take care of people's mental health.
Mm-hmm. Yeah, and so it dovetails so nicely with your last slide, which was such an optimistic and inspiring one to end on, that for the first time in the 2025 WHO guidelines and statement, they're really centering the integration of mental health and HIV. So thank you so much for your important work and this talk and sharing this time with us, Dr. Collins. So Raj, I don't know if you're popping on to remind us that there's different links for the afternoon sessions for those who are joining us for Psychotherapy Day, and we've got about a 7-minute break.
Yeah, absolutely.
Hand it over to you.
Thank you, Dr. Martinovich, for the wonderful moderation. And Dr. Collins, it's a true pleasure to have you here and such important work. And we really appreciate your time and expertise to give us some thoughts and guidance. And so really, thank you for your time. It's a wonderful presentation. And I wanted to let the members know as well that the conference is still continuing. So the people of the future of psychotherapy, please, there are two two links that you have on the initial email, so depending on which workshop, and you'll have about another 5 minutes before that session will start, and then you'll come back to the original link we'll just do a closing. So thank you everyone for joining us today at the Mary Seeman lecture. We've got a lot of people from outside the conference as well. Really appreciate you making the time, and we'll see you next month. So thank you everyone. Take care. Bye.
Thank you so much. Bye.